रुख आएगी, मैं उसको कह रहा था।
जी सर, सर बिल्कुल आऊंगी सर। जी जी सर, डॉक्टर मानूर ने मुझे पहले ही इन्फॉर्म कर दिया था।
बहुत सारे लोग हैप्पीनेस पे प्रेजेंटेशंस देते हैं, especially this is a topic for the psychologist and they talk a lot, and this is another actually a psychological forum जहाँ पे दूसरे mental health professionals भी होंगे. So I thought that okay, I should present something different. So I hope कि जो concept मैं present करूँ वो शायद तुम लोगों को different लगे और पसंद आए. Anyways, let's start for today's presentation, the pharmacokinetics, the important domain where people feel के दवाई लिखनी है, ओपीडी में मरीज को दवाई देनी है और कैसे देनी है. सो इसमें कुछ चीज़ें कॉम्प्लिकेटेड हैं, कुछ चीज़ें बिल्कुल सिंपल हैं. लाइक व्हेन यू वांट टू डिफाइन अ ड्रग इज a substance that changes the way you feel, think, or behave. Some drugs are legal and some drugs are illegal. Drugs include medicines, alcohol, tobacco, and other substances as well. So there are a number of definitions for the drug, but usually it is accepted that it's a chemical substance that brings about physical, emotional, behavioral changes in a person taking it. It could be any substance other than food and water, right? That is intended to be taken or administered for the purpose of altering or sustaining or controlling the behaviors or the illness. Another definition for the drug is, again, related to it, pharmacology. So pharmacon, a drug or medicine in Greek terms. Logos is a science of learning or learning. So learning about the drug or medicines is pharmacology. And when you add psycho into it, means psychotropics. So all the drugs related to the emotional thing. It is basically, again, the understanding that we want to know that this chemical substance, like these days, a new drug is launched, cariprazine, for psychosis. And it has the tendency to have more affinity for dopamine D2 receptors at a very specific sites, not in general. So less of the side effects, more of the focus on specific areas. There are other situations as well. So cariprazine, to understand how this molecule went through a certain process of being invented, when a drug is made, actually every year more than 100,000 chemicals are tried for various indications in experimental situation. Of them, only one or two goes up to the final stages of clinical trials. So the percentages is less than 0.1%. So the pharma companies, the big giants, actually invest hordes of amount of money on research and development. And this research and development project leads to invention of the new specific targeted focused compounds that can actually treat the various disorders. The reason why these molecules are expensive is because when the generic comes in the market, it's very cheap. So the actual formula of the drug, inventing a drug, requires lots of money. And again, as I said to you, that maybe thousands of the molecules are tried every year, and only one of them is successful at the clinical levels. And of all the drugs which are actually approved for the clinical trials, only hardly 1% or 2% of them come into the market as a drug. Most of them are wasted. The COVID vaccine was an exception, and COVID vaccine, because there was a crisis situation, so the human trials were not done, but the vaccine was invented and came into the market. Now there are multiple debates about it, that about its efficacy, about its outcome, about the treatment. So the more older the drug is, the better understanding of that drug you have. So as I was talking to you earlier, like chlorpromazine, promethazine, methoprazine, most of the typical old generation antipsychotic medications who are still present in some of the countries of the world, we know everything about them. Like SSRIs, mein se Prozac was the first drug which was launched, fluoxetine. And of all the SSRIs, the most data available is for fluoxetine. It's safety in pregnancy, it's safety in comorbidities, it's problems with the other drug interactions and blah, blah, blah. So the more older the drug is, the better data you have to prove your point. And this is what, again, is asked in number of the newer drugs, although they say that these are the side effects, these are the advantages, these are the toxic effect, still till the time they go into the phase 5 trials, which are actually the clinical trials in practically human patients coming to you and seeing the doctors, that is the time when actual solid data starts coming up and people start doing the phase 5 trials. So it's complicated. It's not actually a very simple process to make a drug. So whenever you are prescribing a chemical which is administered in a person to treat something, it has its advantages and disadvantages, and psychopharmacology deals with it. Now there is a concept of a prodrug, a drug which is actually having no effects of its own. And when you take it, it alters itself or changes itself to some active metabolites, which are actually chemically active to bring a change. Like probiotics का concept आजकल बहुत ज़्यादा है. A number of indications that people are taking probiotics to improve the immune system, to improve, like there is a drug which is for diarrhea, it's a probiotic. You take it, as such, the own drug is not having anything, but when you take it, it mixes with the intestinal flora and changes into a compound which actually helps in diarrhea. So there are actually multiple facets of the drugs which are coming in the market. Now there is a gene therapy. So you take some samples from a person, you study the genetic formulation, then you make something which can alters the gene and it can help in managing multiple disorders like even cancers and other form of problems. So all of these things, either it's a prodrug or it is again a substance which is used otherwise, they are all having some advantages and some disadvantages because every human being is a different person. It has its own chemistry, chemical structure, and you have to see it. But globally, we have to accept that this is the advantage and this is the disadvantage of a drug. So the pharmacology includes two types of situations. One is pharmacokinetics and other is pharmacodynamics. The pharmacokinetic is actually what body does to the drug. So how the drug goes into the system, into the stomach, from where it is absorbed, where it goes after absorption, what happens to it after absorption, what does liver do to it, what does kidneys do to it, how the drug ultimately goes out of the system. All of these things are pharmacokinetics. And pharmacodynamics is actually the mechanism of action of the drug on a specific places. So what that drug actually does to your body is pharmacodynamics. Now pharmacognosy is identifying crude materials which can act as a drug. And pharmacotherapeutics is the study of use of the drugs. And there is another branch now, gene therapy. There is another branch now, the messenger RNA therapy or toxicology. So there are multiple fields evolving in psychopharmacology or pharmacology, and they are multiplying. So all of these terminologies can be asked in the exam. Pharmacognosy, identifying crude materials as the drugs. Lots of work is done in biometa and microbiomes in the intestines, which have effect in the sensory system, motor system, stomach, lining, blah, blah. So all of those actions needed to be understood before the drug is prescribed to a person. And that is important. Any questions so far? कुछ समझ आया है, कुछ समझ नहीं आया. Whatever is the situation, if you want to ask a question, please stop me. Something in the chat box, let me check. Okay. Okay. So when we talk about pharmacology, the pharmacokinetics, the drug metabolism, the biochemical pharmacology, the molecular pharmacology, the chemotherapy, Then systemic pharmacology, which includes neuropharmacology, cardiopharmacology, gastrointestinal pharmacology, immunopharmacology, respiratory pharmacology. All of these things, they end up into pharmacoeconomics, which is a big field where people assess the risk and the benefits and the cost and the benefits of the specific substances which are prescribed to the patient. And that is an important concern because not everywhere the drugs are available free of cost. So somebody has to pay for the cost. Whosoever is manufacturing it, they want money out of it. So that is a very important thing. And then pharmacogenetics, as I mentioned, new fields are coming in. So psychopharmacology, clinical pharmacology, veterinary pharmacology, pharmaceutical sciences, biopharmaceuticals, toxicology, and medical chemistry. All of these things are actually related to each other. And we as a psychiatrist now are actually broadening our concept, and we want to know more about these things because now we know that there is a genetic predisposition to most of the psychiatric morbidity, like OCD, schizophrenia. Lots of genetic loading is present to cause these disorders. Now we have to understand what actually these drugs do to our genetic system, which can alter and have an impact. So pharmacokinetics, absorption, distribution, metabolism, and excretion, and pharmacodynamics, receptor, ion channels, enzyme, and immune system. So far, easy. Now comes relatively a difficult area where we have to focus more. There is a word which is used: tolerance, dependence, and addiction. So tolerance, Dr. Maruf is probably now these days teaching this, so she knows better than me. Tolerance happens when two biological events occur. One, pharmacokinetic tolerance, drug not reaching the brain receptors. And two, pharmacodynamic tolerance, receptors are damaged or lost. So basically, the typical definition of the tolerance that you need a high amount of the dosage to get the desired effect. Now it's modified with two main concepts. There could be two types of tolerance: pharmacokinetic tolerance and pharmacodynamic tolerance. Pharmacokinetic tolerance, when the drug actually is lost in the system and it never reaches to the target organ. And pharmacodynamic tolerance, when actually the receptors are modified in a way that they stop responding to specific drug. These two concepts are now getting more into practice rather than the typical definition of the tolerance. When we say the absorption, the pharmacokinetics of the drug, so most of the psychotropics, if this is exam again question, most of the psychotropics are actually absorbed from the first part of the intestines, which is jejunum. Most of them, not all of them. Most of them are absorbed from jejunum. And why they are specifically absorbed from the first part of the intestines, there are reasons for that. So when the drug is taken, it mixes with the stomach acids, and some of the drug is actually evaded. The molecules are evaded by the acids and are transformed into something else. To keep the drug active, so the pill that you are taking, when it goes into the acidic medium, it definitely goes through certain changes. Then those changes are reverted into the intestine. So all the drugs that you take, some of them are absorbed from the stomach, but most of them, they actually from acid medium, they passes to the basis medium and they transform into another form. And that is the time when most of these psychotropics, which are highly lipophilic agents, mostly bound with the plasma protein and very much integrated with the lipid solubility, are actually bound there, modified there, and then absorbed from the first part of the jejunum. Some of them are actually absorbed from other parts, but mostly they are transported into the system through the first part of intestine, jejunum. Now, there are multiple layers of membranes or cells in the intestine, and this transportation from gut into the system circulation is complicated, not very simple to be done. Let's try to understand some of it. I won't be able to tell you all of it, but some of it, because this is a absolutely independent big topic related to the absorption of the drugs. So there is the mucus layer, and there is gastrointestinal enzyme system which breaks down the drug. There are bile salts, there are microbiota and pathogens which are actually affecting the drug composition, the pill composition, and their absorption and distribution. And plus, in addition to that, it depends on how you take the drugs. You take it in empty stomach, you take it with food, you take it without food, you take it after food. So this is complicated as well. Like in psychotropics, one drug, loracidon, is said to be, should be taken with meals, because for a better absorption of loracidon, you need at least 300 calories of food inside your stomach. Only then it will be absorbed properly, otherwise it will pass away and the efficacy of the drug won't be seen. So all the drugs, psychotropics, I'm saying, they have a very specific system. If they are taken with the food, because they are lipophilic agents, they usually mixes with the food and absorption is sometimes compromised. So the effect of escitalopram may not be as good as if it is taken in empty stomach or with a filled stomach. And this varies from person to person as well, how much metabolic processes he is having or sustaining, how much exercise they do. So I will come to that as well. So when the drug actually goes into this system and have effects with all these systems, mucus, enzymes, bile, microbiota, food, empty stomach, all of these things have an impact. And they also have an impact through the pH of the drug. What is the simplest way, if you don't understand of all of these things, is to make sure that the psychotropics should be given once a day because they have a long half-life. Two, there is no relationship with the food directly in most of the psychotropics. Some of them, like I have given you the example of loracidon. So what I suggest to the patient is, considering all these concepts, the easiest way that I follow is I tell them to take the medications anything between Maghrib and Isha. Now, most of the people ask me the question that we usually take the food after Isha. And most of the people say that, do we have to take food with the drug at Maghrib time or after Maghrib time if you tell us to take the drugs at that time? So the simple answer to the question is no, you can take the drugs even without food, but between Maghrib and Isha. And in Maghrib and Isha, most of the people sleep around 10 or 11. Well, in Lahore, Laureate probably sleeps around 1:30, 2 a.m. in the morning. Manur would be the best person to tell me about that, of course. But this is complex. So mostly you sleep, if you calculate the time between Isha and sleeping time, it will be 2 to 3 hours. If you take the pill between Maghrib and Isha, these digestive processes are not too much activated because your stomach is still empty. By the time you take the food and these processes are activated, the drug is partially absorbed, and if it has a sedative or somnolence effect, that is done before you go off to sleep, and when you get up in the morning you are fresh and active. This is one of the rationale of giving the drugs. Now, the processes of engulfing a drug into the system involves endocytosis. Now, this was the MCQ. Endocytosis, transcytosis, ligand receptor carrier. Three processes. Endocytosis involves the M cells. Transcytosis involves enterocytes. Ligand receptor carrier is responsible for, again, energy. So it's basically a transport protein and involving energy and ATP and other energy resources to make sure that actively the drug is sucked in and thrown into the system, which is called active transport. So I won't be going into the details of active transport. But endocytosis, engulfing the pill as a vesicle. So the stomach or the intestine actually opens up a little. The drug is trapped into it. There is a vesicle for it. Drug passes through the membrane into the system through the help of the macrophages and then goes into the circulation. Transcytosis means enterocytes, the liver cells, the intestinal cells actually help in the absorption and taking it into the cells and throwing it out into the circulation. Paracellular transport is in between those cells. There is a space and drug passes through them. Ligand receptor carrier means the drug is actually charged with energy, and then the charge is there. The drug is sucked in with the energy sources into the system and thrown into the systemic circulation, which is called active transport. I hope it's not too complicated, right? If it is getting too complicated, let me know.
Sir, I have a question. I can't understand the difference between endocytosis and transcytosis. Um,
Endocytosis and transcytosis. Endocytosis is simply that your stomach lining, the intestinal lining, has actually loops like this, and the drug comes in into it, and they are swallowed into the system and thrown on the other side. Vesicle की form में drug goes there. If you see this picture on the screen, this is again the gap, right? The drug is
yeah.
actually sucked in the form of a small vesicle, and then this vesicle is actually opens up on the other sides and throws the drug there. And the macrophages are actually playing an important role in sucking the drug in and throwing it out. Transcytosis means there are villi in the intestine which moves, right? And the intestines also swallows the drug, same as again endocytosis, but in endocytosis a vesicle is formed. In transcytosis, the enterocytes actually take the drug like the drug passing through the water from one side to another side, or a canal that you dip it in on one side, it floats to the other side and passes on the other side. This is transcytosis. Ligand means that there is available a boat where the drug goes into the boat, and then the boat carries it to the other side of the canal, and then the passengers are offloaded on the other side. Endocytosis, very simple, they goes in, they goes out. Transcytosis, they actually go into something and transported across the leg. Ligand, they are actively actually pulled up and then thrown on the other side. मतलब आया नहीं समझ आया क्यों
नहीं सर आ गया है बस मुझे
कुछ
ये था
आ गया है सो
कुछ आ गया
कुछ आ गया है ये basically again in exam situation they will ask you about a question that what is endocytosis. Endocytosis is just merely engulfing something and throwing it out otherwise. Transcytosis, it goes into the system and goes out of the cells from the other side, right? Through the enterocytes or in between the enterocytes. Two cells, there is a gap in between, the drug goes through them and passes into the system. And ligand receptors, actually, the most complicated, it's a very complex mechanism. Active transport. Active transport needs energy, forcible picking up of the drug and transported to the other side through the active transport energy and protein. That is more complicated. Okay, let's move further and you will further hopefully understand these things more clearly. When it goes into the system from a small intestine, most of the drug is actually uh, bounded with the lipids because they are lipophilic, most of the psychotropics I'm talking about. So they are actually lipid digestion products. And they, in the lipid molecule, these drugs are bound. Then these drugs are having multi-lamellar vesicles. छोटे छोटे उनके बुलबुले बन जाते हैं lipids के अंदर. And then these vesicles actually are broken down into smaller vesicles. The simplest form of it is called simple micelles. And this smallest portion then is absorbed very conveniently through the active transport system into the system. Now, this whole of the process is actually related to the pharmacokinetics, is related to actually the changing of the drug with the lipids molecules, simplifying it and passing of it into the circulation through active transport. All psychotropics are lipophilic in nature, and most of them, not all of them. Sorry. Whenever I say all of them, means most of them. Exceptions are always there. Like lithium is an ion. So lithium in a simple form, if I pull back the slide here, lithium actually is transported through transcytosis. It goes from intestine into the circulation and goes out into the systemic circulation. It never goes into the liver because it's an ion. An ion goes straight in transcytosis. But endocytosis, if you talk about, say, old generation antipsychotics, mostly were endocytosis, was the process. But the new generation antipsychotics have active transport through across the membrane, right? So that is one thing which is there. So this is important to understand. So this is because of the drug affinity to bound to a lipophilic agent or the plasma protein binding, and then it is broken down to smaller, smallest of the thing, which is absorbed straight away to be available into the liver. I'm sorry, it's complex. I understand that. So it took me years to understand this. So of course, I won't be able to explain it to you in just one presentation. But each of the step is a phenomenal process. Phenomenal process. If you start understanding it, you will be much better prescriber than most of them in the market. So understanding of this is important. Absorption from drug administration site to GI to mucous membrane, muscle, skin, subcutaneous tissue, circulation, distribution, tissue organ, storage, bone and fat, uptake, elimination from circulation, biotransformation into the circulation, tissue, liver, and then elimination mostly from the kidneys or the gut, sometimes from the saliva, sweat, and other areas, but psychotropics mostly go like this. Now, as I mentioned to you earlier, now this diagram is again a complicated diagram, but if you can just see the stomach, strong bases not absorbed by passive diffusion due to ionization in gastric acid. Delayed gastric emptying may delay absorption, and particularly ionized bases and enteric coated tablets. Most of the psychotropics are actually enteric coated tablets, which are not dissolved in the stomach. They pass as it is. When they say enteric coated tablets, means they are resistant to be absorbed from the stomach. So the acid won't have much of the effect. And that is one of the reasons why it is said that these drugs should not be broken down into half. It's a very common practice for us. We always do that. Take half a tablet of, say, alprazolam. Well, just giving you an example. And it's a usual practice. But if these drugs are enteric coated, you break them down, they will be actually affected by the acid in the stomach, and they won't be absorbed properly in the intestine, so it will be good for nothing. The patient will say that I am not benefited because this drug was broken down into half, and it has an impact with the acid, and it was not absorbed through the intestine, so it never had a systemic effect. So make sure that when you are prescribing a drug, you should know its composition, whether it is enteric coated tablet or it's a plain one. So most of the psychotropics are actually enteric coated tablets. Paliperidone, for example, these days, if you look at the paliperidone, it seems like it is made up of a plastic. So it cannot be broken down, not at all. It will be very difficult for the patient to actually break it down, cut it, because it appears like a plastic coated tablet, because they want to ensure that that drug has no effect in the stomach and the acid won't have an impact on the stomach, and that drug should be absorbed in the intestines, in the basis environment, basic environment, where it can be absorbed properly and have appropriate effect. Similarly, metabolism by enzymes of intestinal mucosa, chiefly cytochrome P3A4. The psychotropics are metabolized by cytochrome P450 2D6 or P450 system. So here cytochrome P3A is active in the intestine. So some of the drugs which are actually broken down by cytochrome 3A system, if they are having acidic content because of the stomach, they won't have a good effect. So we want to make sure the enteric coated tablets goes through the stomach into the intestines, have effective breakdown by the cytochrome system, and go into the systemic circulation. Does it make sense? Anybody? Are you okay with this?
Yes, sir.
If there'll be anything, just let me know. I know it's difficult, but we have to cover this, unfortunately. This topic is a very hard nut to swallow. So when the drug intake is there, you are considering the absorption system because of the pill manufacturing. So all the XR tablets should not be broken down. Any XR tablets, sustained release tablets, should not be broken down into half, because they won't be absorbed properly and they will have no effect. So sometimes when I want to start a pill, a sustained release pill, so ideally I should give like paroxetine sustained release. I should be saying that patient should take 12.5 milligrams of sustained release of paroxetine for a few days, and if it suits him well, then he should shift to 25 milligrams sustained release pill, and then when it suits him, it can be pushed up to 37.5 milligrams of sustained release pills. But that's not we do. What we do is that we ask them to take half a tablet and then push it up to 1, then 1.5 or 2, whatever the situation is, which make things a little bit complicated. But of course, if we don't want to talk about pharmacoeconomics, I don't want to burden the patient with too many pills and too many money situations. So he will buy 7 pills. Understanding it will be difficult as well. So he will buy 7 pills of 12.5, then 7 pills of maybe 25 milligrams, and then different drugs. You were asking a question. Okay, let me check. What is the difference between sustained release and extended release tablets? Are they both the same? No, they are not the same. They are different. Okay, I will explain it. Remind me. I will respond to this question. Distribution and storage. So free drug, actually the protein bound drug, free drug actually goes through the process of biotransformation. And then it is through the process of biotransformation in the intestines and in the liver, the drug actually is divided into the 4 things. Active drug to inactive metabolites. For example, ibuprofen, paracetamol, chloramphenicol. They are actually active before they go into they went through the process of biotransformation. And afterwards, they are inactive. Then the active drug to active byproducts like acetaminophen, morphine, digoxin. All of these drugs are actually converted into the metabolites which have their own efficacy as well. Then inactive drugs to be changed into the active drug, like levodopa, carbidopa, or steroids. And then drug reactive harmful metabolites like isoniazid to acyl isoniazid. So number of biotransformation processes are taking place in the intestine, in the liver, then the active drug is transported through the systemic circulation into the end organ, which is the brain in our case, and some of it is actually, the excess of it is actually excreted through the urine, bile, sweat, saliva, and feces. Right? This is simple, so there is no complication with that. Chemical pathways of biotransformation. When we say the drug is biotransformed, there are two types of reactions, phase 1 reactions and phase 2 reactions. Phase 1 reactions includes oxidation, reduction, and hydrolysis. Oxidation means oxygen molecules was added. Reduction means oxygen molecule was taken away. Hydrolysis means it was broken down into small pieces. Then phase 2 reactions are glucuronide conjugation, glycine conjugation, acetylation, methylation, and sulfation. Now, all of these processes are needed just to make sure that the drug is active when it reaches the end organ. Phase 1 and phase 2 reaction. Some of the drugs goes through the phase 1 reactions and then phase 2 reaction. Some of the drugs actually never goes into the phase 1 reactions. They go straight to the phase 2 reaction. Some of the drugs goes through all of the processes, right? So it's variable as well. Now, exercise, diet, our body metabolism, person genetic capabilities, thinness, heaviness, bulkiness, fat content, so many things have an impact on the drugs. And this all is actually related to cytochrome P450 system, which could have physiological functions, pharmacological functions, or toxicology functions as well. So this is important. Now, start imagining you are writing a drug and you don't know that this drug, how this is biotransformed into an active metabolite and what it will do. The pharmaceutical company will come and say that this is a wonderful drug. You just try it. It is a miraculous drug, no side effect. You will give it to the patient and the schizophrenia will be cured. Actually, this thing never happens like this. It's not very simple. So why the drug? Patient is taking 8 milligrams of risperidone and still he is not responding to it. There could be multiple reasons for that. Lack of exercise. There is a diet control. Enzyme system is different. It is probably not biotransformed into an active metabolite. Probably it's not reaching the end organs appropriately. Probably there are other drugs competing with it. So there are things are complicated. So I try to keep those things in the mind. Phase 1 reaction, conjugation, metabolites, stable adducts, non-polar species, biliary elimination through the stools. Conjugation, metabolites, polar species, renal elimination, urine. So two things important here. All the polar drugs will be eliminated through the kidneys. All the non-polar species will be eliminated through the gut. Now, how many of you know that this is polar 1 species or polar 2 species? Have you ever thought of it? I don't think so you have ever considered this, but remember this. Parent drug, metabolites into the liver through cytochrome system, usually 450, but 3A, 2C19, 2B6, 2C9, A1A2, 2C8, and 2D6. All of these enzyme systems are actually working to produce the active metabolites. Now, this cytochrome system has a separate entity, long lecture on just the cytochrome enzyme system. It's a strange topic. But majority of the people, especially like various races, Kala, Gora, Chitta, Safed, they have various enzyme systems. Every genetic predisposition from the background, from the ancestors, They have a different enzyme system. And of course, we don't know their backgrounds, their ancestry. And that's the reason why we don't know their enzyme system as well. So it is more complicated how to prescribe the drug. Majority of the people, like 30% of the people, uh, they do the metabolism through P3A45, 30%. Polymorphism, 3%. Induction and inflammation, 3%. Polymorphism with 2D6, inflammation reduction, 20%. If you look at this table, the easiest formula is most of the drugs will be either metabolized through 2D6, the psychotropics I'm talking, or 3A4 system, majority 2D6. Phe4 system is actually complex. It can be inhibited, slowed, induced, sped up. Drugs often compete for the same enzyme system. This is a complicated diagram, POR. And again, cytochrome P450 is the main organ. So when I'll teach you P450, I will teach you this. Now, the question in exam is, what is first pass metabolism? So some of the drug, when taken into the mouth from the lumen of the gut, they actually are absorbed into the liver and go into the systemic circulation. So the metabolites are into the systemic circulation. So the pink pathway is actually, so drug is here in the lumen, then it goes into the liver and then goes into the general systemic circulation. But if the drug, instead of going into the general circulation, goes into the portal vein, goes back into the intestine, and then is absorbed back into the system, this is the first pass metabolism. It means drug metabolism occurring before the drug enters the systemic circulation results in the decreased bioavailability, decreased therapeutic response, and IV route and sublingual route are the common examples of first pass metabolism. So if the drug is absorbed from the intestine, goes into the liver, metabolized there, goes into the systemic circulation, this is first pass metabolism bypass, which is a good thing, relatively, well, not always. And if the drug goes back into the enterohepatic circulation through the portal vein, absorbed back, and then metabolized again, and then sent into the systemic circulation, this is the first pass metabolism. I hope I'm clear about it. Anybody not clear about it? If anybody is not clear, please let me know. Okay. मुश्किल होता जा रहा है टॉपिक. ओके, इसको सादा कर देते हैं. अब सिंपल टर्म्स जो एग्जाम में जरूरी हैं. P450 enzyme system, I won't go into that detail. Now, one of the questions asked in the exam, what is the half-life? So time at which the drug has lost half of its maximum concentration is half-life. Cmax is the maximum concentration of the drug at any given time. Area under the curve, overall drug exposure, and C minimum is the lowest concentration of the drug. So when you take a pill, it goes into the circulation. There is a peak level suddenly, which is called Cmax. Then after some time, it goes into the half level, half-life, and then is eliminated. If the drug is not reintroduced again before the half-life is over, then the drug is waste. Nothing will happen. So this is another reason why if the drug is having 24 hours half-life, right, means it will stay in the system for longer period of time. So you can take it once a day, and it will, what it will do like this. So it will keep on dipping, and then there will be a time after a few days, usually 7 days, when this dips will cause consistent levels in the system, and that state is called steady state. So Cmax, C minimum, half-life. Half-life is when the amount of the drug is half in the system. half is eliminated. If you continuously keep giving the medication with every half-life, for risperidone it's 22 hours, for olanzapine it's more than 30 hours, I believe. So once a day in 24 hours, if he keeps taking the drug, then there will be a time after 7th day that a steady state will be achieved, this state, right? And then the
Sir,
therapeutic advantage,
sorry.
it comes in. Yes.
सर ये जो पिछली स्लाइड है does this mean that generally for all drugs the steady state is achieved after 6 to 7 half lives? Is it?
Usually, yes. Not for everything, but usually, yes.
Okay.
Most of these drugs, they do achieve the steady states in 7 days. I'm talking about the psychotropics only, not the antibiotics or any other drugs.
Yeah.
Most of our drugs, like if you give valproate, right?
Hmm.
The valproate takes about 7 days actually to control the seizure. If you inject valproate, maybe it will control the seizures. Most of the time it won't, because the steady state is achieved at 7th day. Same goes for most of the psychotropics. They achieve a steady state usually around 7th day, some early, some late. It
Sir,
depends the drug to drug. Yes.
there's a question in the chat box regarding the trough levels.
Also
Someone,
explain the trough level. Oh, trough level. Okay. Let me see if I have written it somewhere. If I'll have it, then I'll explain. Otherwise, Manu's question and your question, I will respond later. Quantal dose response, which is called therapeutic index. This is another exam question. What is therapeutic index? What is therapeutic window? So therapeutic index is when the effective dose and the lethal dose, they are calculated, and if the ratio between them is small, the drug is very risky, like lithium. You have to maintain a specific therapeutic window, because if it goes beyond certain levels, it will be toxic. If it will be less than the, again, effective dose, it will be, again, having no effect. So therapeutic index is a ratio between the therapeutic dose and lethal dose. Sorry, effective dose and lethal dose. It's a ratio, TD50 by ED50. So if the drug is having 6 of the TD effect and toxic dose, and ED50 is 2, therapeutic index is 3. For lithium, it is around 1 or 2. For benzodiazepines, it is a lot more. So benzodiazepine is actually having a big safety level, because they have a big, so if somebody takes 20 tablets of bromazepam and gives me a call, I will say, just go off to sleep and see me in a couple of days, and the effects is gone. So they have a big therapeutic window, good therapeutic dosage. Toxic levels are not easy to be achieved, but in case of lithium, the toxic levels can be achieved very quickly. So the therapeutic index is one of the questions that is asked in the exams, and usually the example is lithium and antipsychotic or benzodiazepines. Bioavailability. So fraction of the drug administered reaching the systemic circulation. If a drug is given in a 1 milligrams, it goes into the systemic circulation as 1 milligrams, and it is available in the full doses of 1 milligrams to the brain. This is the bioavailability. Very few drugs have this tendency. Most of the drugs, actually, the bioavailability is less, because some of the drug is wasted in the dissolving process, pharmacokinetics of absorption, then non-absorbed drug, which is wasted, then a drug in the portal vein, it is most of the time wasted. So the fraction of the drug is available. This is called bioavailability. So bioavailability is the amount of the drug which is available at the end organ after the first pass metabolism and all those processes. Drug elimination boost. Very simple. If the drug is actually lipophilic in nature, which are mostly psychotropics. They are eliminated mostly through the liver and the feces, bile and feces. If the drugs are hydrophilic, they're mostly excreted through the kidneys and the urine. Some drug elimination routes like milk, lungs, tears, skin, hair, saliva are also there. Most of the drugs which are actually absorbed from the first part of the jejunum, small intestine, or duodenum, they are excreted through the feces. Most of the drugs which are absorbed through other routes, they are actually excreted through the kidneys. So to simplify, it's not a rule, but to simplify, this is what the process is. Okay, am I okay? Right, I am finished with these slides so far. Let's talk about the other questions. Uh, okay, so the first question, what is difference between sustained release and extended release? Practically, extended release means a drug which remains in the system for more than 24 hours, and sustained release that the drug is released into the circulation slowly after every certain period of time. So that's the main difference. So if you take extended release, means you will take the drug and it will go into the system and have a sustained effect over the period of time. Next 36 hours, the effect will keep on happening. Sustained release and extended release. Sustained release, after every short period of time, a bolus of the drug will be released to maintain the steady state. Slight difference as far as the pharmacokinetics is concerned, major difference if you go into the details of it. The majority of the drugs are actually extended release tablets. Sustained release tablets have caplets in between them. A capsule with small pellets in it. शायद आपने वो आयरन के कैप्सूल देखे होंगे. That are basically again sustained release. Mostly are extended release, which are released, goes into the system, and their bioavailability is longer period of time. Right? Second question.